The broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to our webinar today on the financial impact of hospital readmissions. My name is Katie Tarr. I'm with Lattimore Black Morgan & Kane, LBMC in Brentwood, Tennessee, in physician compensation valuation. Today I'll be hosting the webinar and answering any questions you might have. You can throw them in the question box, or any technical issues you have. Be sure to just shoot me a message in the question section. I'll be responding throughout the webinar to any questions, as well as taking questions for our speaker. We have posted the slides on our website. You can follow along or download those. The link is in the chat section of your browser, and it says you can download the slide deck and that link will take you to the site where you can download that. Today's webinar, to receive CPE credit, just a few housekeeping items. You must be connected for 90% of the webinar, and you must answer 3 out of our 4 polling questions today. And I'll be reminding you of that as we go throughout the presentation. Also, a few items coming up for TNHFMA. We will have registration opening shortly for our next webinar next month, which will be, the title will be Solving the Problem of Uncompensated Care. That will be on July 14th, and that will be presented by John Whaling and Lindsay Van Cleve of Barnard Health. You can visit our tnhfma.org/webinars website for more information. And then you can also save the date for the Fall Institute, which will be held October 21st through the 23rd in Gatlinburg, Tennessee. And more details, as well as a formal save the date, will be coming out shortly. And just a reminder for those of you that have just joined us, to receive CPE certificate, you must be connected to the webinar for 90% of the duration, and you must respond to at least 3 of our 4 polling questions today. With that, I will begin to introduce our speaker, Jim Hoffman. Jim brings over 20 years of technology and operations experience to his position as the COO of Bessler Consulting. Most recently, he was president and general manager of Acura Revenue Management for MedAssets. And prior to the acquisition of Acura Healthcare by MedAssets, he served as the president and chief operating officer of the Acura Revenue Management business unit and the chief operating officer of Innovative Health Solutions. His prior experience includes technology development in the healthcare, finance, telecommunications, and entertainment industries, and Jim is a graduate of the University of Virginia. And with that, I will turn it over to Jim.
Thanks, Katie. Good morning, everybody. So today in the webinar, we will be looking at the history of the Readmissions Reduction Program from CMS. We'll look at how that's been impacting hospitals across the country and specifically in Tennessee. We'll look at some of the calculations that are involved in the program and how we can look at the financial impact for specific hospitals. We'll also look at a way that you can better understand some of the readmissions trends and underlying causes at your specific facility. And finally, we'll review the ways in which some of the new reimbursement trends will impact readmissions going forward. The 3 main points, hopefully, I'd like you to take away, though, all of that being said, is 1 is that you've got an incentive to reduce readmissions in your facility. 2 is that you really can do that. And 3, you might not have to do as much as you think you do. Bessler got interested in readmissions a few years ago when the penalty came into effect back in fiscal year 2013, and we started asking some of the CFOs at our hospital clients how they thought the program was going to impact them, and what were they doing to reduce readmissions. And we got sort of a surprising answer, which was that they didn't want to reduce readmissions. They felt that the cost structure at their hospital was such that they'd be much better off if they simply took the penalty and also received the reimbursement for those readmissions. And so we started wondering, did CMS get the incentives completely wrong, since that was almost unanimous in terms of what we were hearing from CFOs. So that was what got us interested in it, and much of this presentation talks about how we investigated that question. And with that, Katie, it's actually time for the first poll question.
All right, and just a reminder, to receive CPE credit, you must answer 3 of our 4 polling questions. This is the first one. And the first question is, a hospital is better off financially receiving the reimbursement for excess readmissions, even if it has a readmissions penalty. True or false? Again, as always, just a reminder, there is no penalty for a wrong answer. Just simply need to be sure that you answer 3 of the 4 polling questions today to receive the CPE credit. I'll leave the question open for a few more seconds. We have about 80% have voted, and give you a few more seconds to go ahead and make your selection. All right, I'm going to go ahead and close the poll. And as you can see, the results are pretty much almost equal, although 54% saying false and 46% saying true, Jim.
Okay, thanks. All right, so the story of the readmissions program really starts with the Affordable Care Act, which introduced a number of quality-based readmissions reductions or reimbursement reductions, including value-based purchasing, the Hospital Acquired Conditions Program, which started just this past October, and then the focus of our presentation today, the readmissions penalties, and as CMS calls it, the official name is the Hospital Readmissions Reduction Program, or the HRRP. So when you put all those programs together, along with some other reductions, it can easily be 3, 4, 5, 6% of your Medicare reimbursement. And if you're a typical facility, you maybe have approximately 50% of your patient volume is Medicare. That can really add up. And if you look at the trends across the country, especially on the bottom 5 percentages for the average operating margin for hospitals in each state, they're a big percentage of the hospitals overall that you have a 3 or 4% reduction in your Medicare revenue. It can eat away most or all of your bottom line. In Tennessee, you're doing fairly well at 7.8%. You're right around the middle. But still, if you took away 2 or 3% of that number, you would definitely feel it. So the HRRP is focused on the concept of excess readmissions. We'll be talking a lot more about exactly what that means, but the important thing to recognize is that even CMS knows that you can't reduce all of your readmissions, and that's not the goal in any type of readmissions reduction effort. There are simply certain cases where it's really unavoidable. So the program applies to what are referred to as subsection D hospitals, which are basically short-term acute care hospitals. Hospitals like critical access, VA hospitals, cancer hospitals in Puerto Rico, for example, are not part of the program. Medicare Advantage claims do not count towards the penalty calculation. And as you may know, hospitals in Maryland have pretty much their own system for everything when it comes to Medicare. They're included in the program when it comes to looking at your performance, and if one of your patients from Tennessee happens to be readmitted in Maryland, for the most part, that would be counted against you. But they have their own program, which is actually an incentive-based program in Maryland. And just to keep things interesting across the various CMS programs, the inpatient quality reporting readmissions calculation uses a different subset of hospitals than the HRRP, unfortunately. So when CMS was looking at how to develop and administer the program, they considered several types of systems, including an incentive-based system for the whole country, but they settled on a subset of cases that would apply to all of your, would apply to the penalty for your entire facility. And the first 2 years of the program, the 3 measures, as they call them, were AMI, or heart attack, heart failure, and pneumonia. And starting in fiscal year 2015, they added measures for COPD and total hip and or knee replacement. And in all of these cases, CMS was looking for cases that, or types of cases that had high volume, high levels of readmission, and where there was existing proof that readmissions could be reduced based on clinical studies and trials. And so those 5 measures this year account for about 21% of Medicare claims, but as I think most people understand by now, they drive 100% of the readmissions penalty, which applies to all of your Medicare discharges, not just the specific readmissions cases. One important thing to understand about the program is that it's always looking in the past and looking at your past performance. A good example of this is coronary artery bypass graft surgery, which is going to be coming into effect in fiscal year 2017. But the history of this is interesting. In the fiscal year 2014 IPPS final rule, which came out around August of 2013, that was the first time that CMS mentioned CABG, people refer to this as CABG. First time they mentioned CABG as a potential new measure for readmissions. And the following year, in May 2014, in the 2015 proposed rule, they officially proposed adding CABG as a new readmissions measure for fiscal year 2017. And in the 2015 final rule, they said, yeah, we're definitely adding CABG in 2017. And if they maintain the same review period as they have for all the other years in the program so far, carrying that forward, the review period for CABG will be July 1st, 2012 through June 30th, 2015, when it starts in 2017. So you can see the very first time they officially mentioned it, even as a potential new measure back in August 2013, you were more than a year into the review period already. So it's important not to start paying attention to potential new measures only when CMS officially announces them. They do broadcast it a little bit in advance. In this case, you would have had at least 2 years of the review period to have tried to make a specific effort around those types of cases. But not always, because another example is in the 2016 proposed rule that just came out last month, CMS has proposed to expand the definition of the pneumonia measure so that it would include about 65% more cases as it has in the first 3 years of the program. And again, that would be a 2017 change. And so the first mention of that came out in May of 2015, and the review period will end about a month later, or 3 weeks from now. So you may have thought that you were doing fine on the pneumonia measure and not even had a penalty, but they may retroactively determine that, nope, you really weren't doing that well back in 2012, even though we're not telling you about it until 2015. So it makes the argument that a general approach and concern about readmissions is appropriate. The maximum readmission penalty, again, that applies to all of your Medicare discharges, increased from 1% in the first year to 3% this year, and that's the maximum going forward. It is interesting to note that in 2015, there are 39 hospitals that are receiving that maximum 3% penalty, but there are also 39 hospitals that are receiving at least a $1 million penalty, and there's only one hospital that is on both of those lists. So it's a good demonstration of the fact that the percentage of your penalty, or your penalty adjustment factor, as CMS calls it, readmissions adjustment factor, isn't the main driver of your dollar amount penalty. And with that, Katie, it's time for poll question 2.
All right. And Jim, we did have one question just regarding the hospital margins you quoted. Is that for all payers or just Medicare?
It is for all payers.
Okay. And that is what the person thought. They just wanted to ask that question. So I will now launch our second polling question. And again, to receive CPE credit for today's webinar, you must answer 3 out of the 4 polling questions. This is the second polling question. So if you did not get a chance to answer the first, you must answer this one as well as the subsequent questions to receive CPE credit. The question is, do you know your hospital's readmissions penalty factor? Yes or no? And again, no penalty for the wrong answer. I will leave the polling question open for one more second. We have about 80% responding. And I will go ahead and close the polling question. Based on our results, we have about 60% reporting they do not know their hospital's readmissions penalty factor and about 40% stating they do.
Okay, thanks. So the current structure of the program has received a lot of criticism. A lot of this comes out in the comments to proposed rules each year. CMS issues them. One of the top concerns is that socioeconomic factors are not taken into account during any of the calculations. There's a lot of evidence that things like income level, whether the patient speaks English, whether they own a car, whether they live alone. There's a lot that shows that those types of factors can drive readmission rates, because a lot of these things drive whether they can go to their follow-up primary care physician appointment or get their prescription filled. So the program does not take any of that into account. CMS's response is that the fact that there are a number of clinical factors taken into account in their predictive algorithm reflects those chronic conditions that they believe have underlying impacts from these socioeconomic factors. Another is that the law that created the program requires CMS to differentiate between related and unrelated programs, readmissions, and CMS does not actually follow through on that. They have, over the past few years, added some exceptions to the rule, such that the certain types of readmissions that are actually planned, the number of follow-up visits that are required for certain types of cases are excluded from the calculation. But for example, if you are discharged as a pneumonia patient and you come back 2 weeks later with due to an automobile accident, there will be a penalty for that. So even though they're completely unrelated, and CMS says that their planned and unplanned readmissions logic is a good proxy that addresses the spirit of the law. So that's how they address that. But on the other hand, as we'll see, there's a flaw in the language that creates the program that causes the impact of the penalty to be much higher than Congress intended. And in that case, CMS simply says that they're following the letter of the law and there's nothing they can do about it. Another factor is the concept of preclusion scattered throughout the Affordable Care Act and specifically within readmissions. There are a number of cases where the law simply says that these decisions that are made related to the program by the HHS secretary cannot be appealed, and that's really never been used to that extent, and it hasn't been challenged yet, but it is something that's different in this program. Some people argue that the fact that only a subset of your cases drives your entire penalty encourages the concept of teaching to the test, where you're only focused on those types of readmissions. We're not necessarily seeing that, but it's something that's out there. Another factor is that larger hospitals can be penalized more than smaller hospitals, because there is a minimum number of cases for each measure that CMS reviews. So you may see one hospital that's a smaller hospital without as much volume that has no penalty, and somebody may view that as an indication that that hospital has a low readmissions rate compared to a larger hospital, but it may simply be that they don't have enough to generate a valid sample, even though their actual readmission rate is much higher. And so that creates a quality perception based on the results of the penalty calculations. As we'll see, each of the 5 measures has its own penalty calculation, and so that if you are performing worse than average on one measure, you'll be penalized. But if you're performing much better than average on other measures, there's no offsetting credit in the calculation. Another factor in readmissions that's fairly well established is that the post-acute care that a patient receives can have a direct impact on readmission rates, but CMS doesn't provide the data for hospitals to be able to track that information, and we'll see the data that they do provide in a little bit. Another argument is that some people have, I guess, pointed out that the fact that one hospital may be performing so bad on a particular measure that some of their patients are simply dying in the hospital may make their readmissions rates look better because a patient who dies can't be readmitted. And then finally, based on the way the calculation works, you can have a very frequently admitted patient coming in and out of the hospital who can trigger several separate penalties for the same spell of illness, and many people believe that's not necessarily fair. There's a little bit of hope in Washington around some of these concerns. Last year there was a bill in the Senate that was a bipartisan bill, which is fairly rare last year, and that bill would have required CMS to adjust for socioeconomic factors in its penalty calculations, but it really didn't get out of committee. There was no progress on that last year, but I guess the good news is that it's on the radar in DC, and there may be some changes coming at some point. So as you'll see, the problem is that it's fairly complicated to explain where some of these deficiencies are, especially when we get into the calculation in a little bit. And so the idea of efficiently explaining that to somebody in Congress or their staff and having them be able to drive this change was probably a little bit of a tall order. Now let's look at the impact of the program on hospitals across the country. You can see between 2014 and 2015 we had a jump both in terms of the number of providers being penalized and the total penalty, and that was driven by the addition of the two new measures that I mentioned a little earlier. But what we're looking at here in total is $428 million this year being taken out of Medicare reimbursement only from this program. And then I'm going to look at a number of maps here, and as you look at them, the darker color is higher numbers on the map, and you'll start to see on them a number of trends in terms of the eastern half of the country being darker than the west. First here is the percentage of hospitals in a state with a penalty in 2015. You can see the top list here. Three states in Washington, D.C. all have every hospital in their state being penalized. And almost the top 10 have at least 90% being penalized. And when you look at the total penalty amount by state, same type of trend. You see a lot of the larger states, obviously in the more populous states, being highly penalized. But New York alone, $44 million. And then finally, the average penalty per hospital, each hospital being penalized. Here in New Jersey, where I'm from, we have the unfortunate distinction of being number one on the list at over $400,000 per hospital, and we're also on that list of states where every hospital is being penalized. So almost every hospital in New Jersey, every hospital in New Jersey is seeing on average $400,000 in penalty. Luckily, in Tennessee, you're not on any of these top 10 lists, so that's a good thing. Now let's look in particular at Tennessee. You've got 98 states that or 98 hospitals that are subject to the readmissions program. 83 are being penalized. Only 2 with the maximum penalty, and in total about $10 million in penalties for an average of 123. And this is a distribution of the penalty levels across the state. So you can see all the way at the right is where the full 3% penalty is being hit, but most people have they're 1% or less who are being penalized, most hospitals. Now we're going to look at the calculation of a hospital's readmission penalty, and I will say ahead of time not to get hung up on the details as we go, because there are a number of slides later in the presentation that have the sources for all of the calculations and the data sources that we used. But Katie, this is now time for poll question 3.
Great, thank you, Jim. So we did have one question between the last polling question and this one. The question was, so the no credit under the measure means that even if we get better on heart failure, better than the average, that does not help pull up the other measures?
Correct. The best you can do is no penalty.
All right, I will now issue the third polling question. Again, you must answer 3 of the 4 polling questions today to receive CPE credit. And the question is, have you calculated your hospital's readmissions penalty amount? Yes or no? We have about 70% responding. I will wait a few more seconds. Again, no penalty for a wrong answer. All right, I'm going to go ahead and close the voting. It appears 70% have said no, while about 30% have said yes.
Okay, thanks. Well, for the 70% of you who have not, if you're interested, we'll be showing you. So in order to calculate the penalty, we need 3 things. Well, actually, the penalty itself isn't that bad. In order to calculate the penalty, you need the readmissions factor, and we'll show you how to do the actual penalty calculation, which is fairly straightforward. But things get a little bit more interesting, I think, when you understand how they calculate that 0 to 3% penalty factor, and that's what we'll talk about first. So in order to calculate that factor, you need 3 things. You need excess readmissions ratios, the aggregate payments for excess readmissions, and the aggregate payments for all of your discharges. So the factor itself is available in the final rule, and CMS publishes that, and it ranges from 0.97, which reflects a 3% penalty, up to 1, which is 0% penalty. But CMS doesn't publish the actual dollar penalty by hospital. They do usually issue a press release that talks about their estimate for the impact on the entire population of all hospitals, but not by hospital. So we'll show you how to do that. But first, so for the readmissions adjustment factor, as I said, the first thing you need is the excess readmissions ratio. And the way that is defined is the risk-adjusted predicted readmissions divided by the risk-adjusted expected readmissions, which is how they feel you're doing compared to the average hospital with the same patients. And that is calculated for each measure on its own. And again, if that's less than or equal to 1, then there's no penalty, but it doesn't matter how far below 1, as I mentioned. It doesn't matter how good you do, you will not receive any credit on that one. And CMS also, I'll show you later where those are provided for you. The problem with the excess readmissions ratio, though, is that it is the traditional black box, and CMS, although they provide them, admits that hospitals can't calculate them on their own, because in order to do that, you actually need 4 years of Part A and Part B claim and enrollment data for every hospital in the country. And obviously, CMS is the only source for that information, and they don't share it. What they do share is for each of the 5 measures, a very detailed document that explains their calculation for how they predict how many readmissions you should have. And each of these documents is about 100 pages long. It's very heavy math, and it's hard to understand as you go through it. But what I did notice as I went through them was that they list for each of the 5 calculations the C statistic. And if you remember from any statistics class you may have ever had, the C statistic is a measure of the accuracy of a predictive model. And it ranges from 50%, which is the same as flipping a coin, to 100%, which means it's always right. And statisticians will tell you that you need one of at least 70% to consider that to believe you've got a valid model, and you need at least 80% for it to be a strong model. And if you read through these 5 very long documents, you'll see that the C statistic for each of the 5 measures ranges from 61 to 65%. So to some extent, there's a question whether the foundation of this entire calculation is very strong, but right now it is what it is. The next factor you need to calculate your readmissions adjustment factor is the aggregate payments for excess readmissions. And you can see in red here, I mentioned earlier that there is a flaw in the language of the legislation that created the program, and it's based on the sum of the base operating payment, DRG payments for the measure, times the excess readmission ratio for the measure minus 1. And we'll come back to that one in a little bit. But the definitions are here on the page for the base operating DRG payment, the wage-adjusted DRG operating amount. You can get all of these from various CMS files to calculate these, and you can get the excess readmissions ratios from a document that CMS issues that I'll show you later as well. So that's not too hard to calculate on its own. And finally, the aggregate payments for all of your Medicare discharges is pretty straightforward as well. And then in order to calculate the readmissions adjustment ratio, again, that CMS does provide to you, we have the formulas on the screen here. I'm just going to read them. And then we look at the greater of that calculation or 0.97. Really, the most important factor in this section of the presentation is that section that I mentioned, that page a couple of pages ago, that shows where that flaw in the calculation is and how that will drive your whole penalty. So we'll be coming back to that. One thing to note, because the 2016 proposed rule just came out, CMS does list a readmissions adjustment factor for every hospital, a preliminary number. You should know that that number really doesn't mean much of anything at this point. They did not recalculate yet the excess readmissions ratios, which is really the thing that determines whether you have a penalty in each of the measures. And so they use last year's ratios with a year later of volume information, so it doesn't reflect anything about how you're doing on readmissions year over year. So if you do look at a difference in that number from last year to this year, know that it can change substantially when the final rule comes out and they have all the information in the calculation. Frankly, I'm not quite sure why they even issue a number in the proposed rule, because it's confusing at best. And finally, to calculate the actual penalty, you take the total of your base operating DRG payments times a readmission adjustment factor. Again, you don't have to calculate that factor. The final version is in the final rule, and that will give you your penalty amount. And we've got plenty of resources for this in subsequent slides, so you can do that. And also at the end, something else that will help you do that calculation. But if you remember why we looked at all of this, to try to figure out if hospitals were better off taking the penalty and the revenue for the readmissions or getting rid of both. Now we know the penalty portion of that calculation. The next thing we need is for the excess readmissions, the ones that are driving the penalty, what's the claim revenue? So we can get the number of excess readmissions from the hospitalcompare.gov website, multiply that by the average payment per claim, which you could either get from your own more detailed information within your hospital, or we, in our case, when we were looking at this, we used the MedPAR file. So that's relatively straightforward to calculate. And finally, we would need the cost, because in theory, if you're reducing readmissions, you're reducing your cost to some extent. And the answer to that is not necessarily as clear as it might look at first. You may be looking at, if you had to reduce excess readmissions by 50 admissions across the 12-month period, that would be a lot. And even if you had to reduce it that much to get rid of your penalty, you're still going to have things. Obviously, you've got your hospital building. You're going to have things like MRIs and CAT scans and techs that are waiting to run those for you. Unless you could remove all 50 in one unit in one short period of time, it's probably not going to really impact your staffing at all. You're really just talking about, ultimately, drugs and supplies related to those excess readmissions. And what we're trying to figure out in that case, then, is what's the variable cost for these patients at the margin. And when you look at that, there's not a lot of good information in the literature, unfortunately. There are a number of studies, but they're all really back from the 1990s that estimated the variable cost for hospitals to be anywhere from 16 to 40%. When we were doing our calculations, we used 20%, which we thought was fairly conservative, but as you'll see, it really didn't make all that much of a difference. But if you are going to do this, you need to figure out the source of the cost. So your best source is something, would be a well-maintained cost accounting system if you happen to have one, but not everybody does. You can use cost-to-charge ratios, which is what we used in our work looking at this across the whole country. And those are easily available, but they're not necessarily as accurate as you might like. And then there are other estimates floating around. You'll see a number in a number of articles of a $9,600 cost per readmission, but that's an older number that's actually the cost to CMS. So it's really apples to apples when you're trying to do what we're doing. So in the end, for us to calculate our variable cost per readmission, and as we're looking at our formula here, is we took the average charges per claim for each of the measures, which we got from MedPAR, times every individual hospital's operating and capital cost charge ratios, times the 20%. So then with all that information, we were able to come up with the answer for our original question, which is when you compare the cost savings and the reduction in the penalty for readmissions, how does that compare to the revenue related to those readmissions? And what we found, we'll talk about why, is that every single hospital in the country that's being penalized would have a positive financial impact if they eliminated their excess readmissions. And we'll look at why in a second, but just a few more comments about the way we did our work here is we had to assume the same average cost for all admissions, including the readmissions, and there are a number of studies that indicate that readmissions end up being more costly than the original admission, but because we're looking at averages per hospital, we couldn't make that differentiation. Next, there are a number of cases where we get data from CMS in 3-year chunks because of the way they calculate the penalty over a 3-year review period. And so we always used 1/3 of that when coming up with our annual impact, and that was simply because that was the only data that was available to us, but it doesn't take into account any variations from year to year for a particular hospital. This definitely isn't true here in the Northeast for the most part, but there are parts of the country where there's enough demand that theoretically you could replace those readmissions that you eliminate with other non-readmission admissions. If you're in the position to do that, then those incremental admissions end up being very profitable because that whole variable cost methodology works in reverse for new patients that are added. There's very low cost related to them. Again, we use cost to charge ratios. If you're trying to recreate these calculations for your facility and you have better cost information, then you would definitely want to use that. And then finally, we did not consider any costs related to reducing readmissions. Many hospitals will implement a program that includes, you may have nurses or social workers following up with patients after discharge, either in person or on the phone, and so obviously there's a cost to that. So let's go back to why we found such a consistency in the results. And it goes back to the definition of the average payments or aggregate payments, for excess readmissions back from the law creating the program. And again, for each of the measures, we're looking at the sum of the base operating DRG payments for the measure. And you'll see for several years, CMS, MedPAC, the advisory group on Medicare and Medicaid for Congress, submitted comments to CMS basically saying you're not doing it the right way. You're not doing it the way we intended. So they provide an example that's similar to this. Consider that you have 100 pneumonia cases in a year, and that on average across the country, hospitals would have had a 20% readmission rate. So CMS, under its calculation of the excess readmissions ratio, considers that your expected readmissions of 20. Then consider that you assume you actually had 24 readmissions, and then they run it through their algorithm that doesn't have the most accuracy necessarily, and say they think you should have had 22. So that would be 2 excess readmissions compared to the national average, and then you have an excess readmissions ratio of 1.1. And then further assume that for each pneumonia case, on average, you were receiving $10,000 from CMS. So for those 2 excess readmissions, those 2 patients beyond what CMS thought you should have, you would have received $20,000 in payments from CMS. Unfortunately, when you take the literal reading of that definition, I'll go back to that slide, the sum of the base operating payments for the measure, CMS calculates it as every pneumonia case. So they take 100 times $10,000, which is $1 million, times the excess readmission ratio minus 1, which is 0.1, times $1 million is $100,000. And that $100,000, and this works for each of the 5 measures, is what flows through the calculation and determines the proportional amount of your Medicare reimbursement that's reduced by the penalty. I'll show you the impact of this across the country. So this multiplier effect is what people refer to this as. There are a couple of things on this slide that are worth noting. Across the country, when you look at excess readmissions, for 2015, there were only about 8,400 excess readmissions, which is very little spread across the 3,400 or so hospitals that are impacted by the program. And then you look at the payments that were received for those 8,400, which is only $86 million. However, by doing the calculation the way CMS does, there's a $428 million penalty. So for each dollar that you give up in Medicare revenue related to these readmissions, you'll get a $5 reduction roughly, across the board at least, in the penalty. So there's a strong incentive to reduce readmissions. As you see, we're not talking about a large number of cases. We've drilled down for individual hospitals into the number of excess readmissions that they have in measures where they're being penalized. And in many cases, you're talking about a single-digit number. So it can really have an impact if you focus on those measures. And the key, as we'll see a little bit, is doing it faster than everybody else. We look at the same calculation in Tennessee. It's also fairly stark here. 290 excess readmissions per year across the entire state, $2.3 million in penalty in reimbursement, but $10.2 million in penalties. So you're a little bit more than a 4 times ratio here. So this is what we're looking at here, and this is why every hospital does better by reducing their readmissions than by taking the penalty and the revenue. The next couple of slides provide the details for where you can calculate how you can calculate the data, where we got the data we used, and the resources slide shows links, so you can, if you feel like reading those 100-page predictive model documents, you can get to those as well. So now that you know that it makes sense to reduce your readmissions, I want to talk about where you can get some data and how to start looking at it. CMS provides something on the QualityNet website, which is a place for them to exchange information with providers on all of their quality-based programs. And there is a file related to readmissions on that website that comes out every year. So Katie, this is time now for the final poll question.
All right, thank you, Jim. Just a reminder again, to receive CPE credit today, you must answer 3 of our 4 polling questions. This is our 4th and final polling question. And the question is, does your hospital download its QualityNet readmissions file? Yes or no? Right now we're at about 70% voting, and I will wait a few more seconds to let everybody get their answers in. Again, no penalty for a wrong answer, and this is our final polling question today. I will go ahead and close the polling question, and it looks like we have about 50% even saying yes and no, that they do and do not download the hospital QualityNet readmissions file. So about 49% and 51%.
Okay, thanks. Well, that's actually a much higher number than I usually see when I ask people this question. Most people don't know that it exists, so this group is doing much better than average for sure. So the website, if you don't know where it is qualitynet.org. And the idea behind providing this file is to allow you to review the claims and the calculations that CMS used to calculate your penalty. You really can't confirm the penalty calculation as we've shown, because you can't replicate the expected readmissions ratio calculation, but it does provide some of your overall readmission statistics. I'll show you what this document looks like. Just an Excel spreadsheet. It's got 6 tabs in it. The first has I think it has 7 tabs, but the first or second tab has this summary information, and you can get the readmissions ratio here, the excess readmissions ratio here. It also comes out in the final rule files. But this shows for each hospital, for your hospital, how you're doing on each of the measures and which ones are driving your financial penalty. And then for each of the five measures, there's a separate tab, and it's got very limited demographic data, just barely enough really to identify the patient. But I would recommend looking at this, especially if you're on any given measure, you're really right on the edge, because we have seen situations where patients that were listed on this file were not in the hospital's claim data on the CMS mainframe. So some strange things can definitely happen here, and it's worth verifying that they're getting it right. And for each of the tabs besides the demographic data, there are, each tab actually is a set of flags that are required to try to replicate that predictive algorithm. So what you can verify with this file is that the right claims themselves and the number of claims are being used, and then otherwise all you can really do is verify that CMS is multiplying and dividing correctly based on their formula. But what we've seen is that if you can take this data that's not really provided in a particularly useful format, and with the right tools, you can start to make it a little bit more useful. I'm going to show you a series of charts now that we used a tool called Tableau, which is a data visualization tool, to create these. But you could do it with Excel if you're particularly good with Excel, or another tool that's very popular in healthcare is called ClickView with a Q. So anything that will help you pull data together and easily create charts and graphs would be useful. So some examples of what you can do with the data just in this file without adding anything else to it and still have it be useful. You can pull the readmission summary by measure. I'll go through these fairly quickly. You can look at your readmissions trends year by year. We often see, especially after the first year and people were hit with a penalty, and they may have implemented a program or gotten a grant to try to reduce a particular type of readmissions based on some of the best practices that are out there. And then maybe that grant or program, the dollars have to be then dedicated to something else in the subsequent year, so you may see a jump back up. So for the first 3 years, this is actually a fairly typical type of trend for each of the measures. Within the program, there are a number of types of claims that can get excluded from the calculation, including people who left AMA or they weren't eligible for Medicare for the previous 12 months. Because of the way the calculation, the CMS predictive model works, you need a year's worth of prior claims data. So all of these, you can find out how many were actually, they were technically readmissions. They came back to your hospital, but they didn't get counted for your penalty. So it's good to know these are sort of near misses in your penalty calculation. One thing that people are often interested to see, because this is probably one of the few places where CMS provides any hint of data related to other providers, for a given hospital, is you can see which readmissions or which other providers your patients were being readmitted to. They don't have to be readmitted only to your hospital to count in the program. If they're readmitted anywhere else, which normally you wouldn't be able to see, it counts. So you can see that. And that's an interesting, it's important to keep this in mind if you're considering, back to our original question, where am I better off getting the payments or the penalty? On average, for Medicare, about 20% of patients are who are readmitted go to another facility other than the original discharging facility. So even if you feel like you still believe that the payments are better than the penalty, keep in mind that 20% of them you're not even getting paid on because they're being readmitted to another hospital, but you're still being penalized on those. You can look at the age ranges to see if that's something that should be taken into account, for example, in your discharge planning. It's interesting when you look at the days related to the admissions and discharge and readmissions, because they can give a hint potentially to some underlying operational issues. So you look at this example on heart failure, for example, on the top, you can see that 40 patients, by far the most, were readmitted who were discharged on a Friday. And that might make you think maybe there's something going on Friday discharges related to heart failure that we should look at. But you can drill down further and look at the total number of days for total number of discharges by day of the week that were readmitted. And you can see that on Friday, you have the most readmissions simply because there are the most discharges. There are 132 here. But Sunday and Monday, in comparison, you have a much higher percentage of patients being discharged or being readmitted who were discharged on those days. So a different way to look at the data. This chart here, it shows the comparison of the relationship of the length of stay, the index stay, the original stay, versus the readmission. And this really just shows that the length of stay of the readmission generally is longer than the original discharge, which is one of the drivers as to why readmissions typically cost more than the original admissions are. You look at the gender for each of the measures. This is very interesting, I think, the number of days to readmission, another indicator potentially of some underlying operational issues. You look at COPD, for example, a large number of patients in this data being readmitted the next day after discharge, which makes you wonder if should those patients have been discharged in the first place. Under heart failure, you can see a spike after about 14 days. And so you may wonder, or actually after about 7 days, so maybe there's some program in place that does follow up, but it's only attempted for the first week. You have to look at how that might apply to what's going on in your hospital. This report is particularly interesting, I think, because it's a good starting point for some further investigation as to the underlying causes. For each of the measures, you can look at the discharge status. Are they going to a nursing home? Are they going to home? In this case, for our first measure here, AMI, you can see that if you are being discharged to a nursing home, you have a 36% chance of being readmitted, which is higher than any of the other options. And so with that information, you can go back and look at the medical records, look at the discharge plan for that patient, figure out where they're being sent to, and see if there are any trends there where you're seeing readmissions higher from a particular nursing home. And then, of course, you'd have to delve into that detail even a little further, but it's a good starting point. This last chart would show you the related versus unrelated readmissions. So if you have a clinical expert look at this, they can give you a better sense on what population of patients who are being readmitted you can actually do something about, because for the most part, clinically, you can only address the ones that are related from a clinical standpoint. And you can get even more value out of this data and out of these types of charts if you augment it with more hospital-specific or more claim data for the underlying medical claims, which you can either get out of your own system or out of the common working file for Medicare. You could also do things like bring in census data as a proxy for some of the underlying socioeconomic factors. So it's a good starting point to try to start to understand what the causes are for readmissions at your facility. And it's a data file, as I mentioned, that a lot of people don't know exist. So it's definitely worth pulling this down and looking for it. As we look ahead at some of the things going on in the industry, obviously a big focus of CMS has been bundled payments. There were 4 prototype bundled payment plans that were piloted by CMS. 3 of the 4 would really effectively pay you nothing for readmissions because you get a single lump sum payment for the 30 days worth of care. So in that case, you're getting 0 for readmissions, which is worse than the current system. But that's clearly the way they're heading. And back in January, CMS announced that they set some goals for themselves so that 30 to 50% of payments over the next few years, they want to increase that to that percentage for alternate payment models such as ACOs and other bundled payment programs. And then for whatever's left over under traditional fee-for-service payments, they want to move the percentage up to 90% being focused on quality or value by 2018. So CMS will continue to move towards penalty and incentive programs around all of these quality issues. The one thing to keep in mind is that, as I mentioned, the way that excess readmissions ratio works is that you're always being compared to the performance of other hospitals across the country. So in order to improve your performance and lower your penalty, or stay away from the penalty in the first place, you need to be improving faster than everybody else is improving, because you're always being measured with each other. So unless even if you're staying the same and everybody else is getting better, then your penalty can actually go up, even though you haven't gotten any worse in terms of your own performance. And finally, a number of other payers are starting to implement readmissions penalties, and trying, in some cases we've seen, even trying to make this change in the middle of a managed care contract, where they'll just send you a notice that they're going to start following the CMS penalty calculations, and we've often seen people or payers say, we won't pay you anything essentially for any readmission in the 30 days unless we determine that it's not related clinically. So even though it's not really an apples-to-apples comparison to the CMS program, we're seeing a lot of managed care companies try to relate their new penalties that they'd like to implement to the CMS methodology, and so it's something to keep an eye out for. And it's almost certainly something that's going to continue. What I'd like to leave you with is, you can certainly try to follow along all the steps in order to calculate your penalty and verify some of the underlying data. But we have created a free tool, if you'd like to download it from our website, that will let you plug in all of the factors. Again, if you have better data, such as better cost data or better estimates for your next year's Medicare volume, you can plug those into a calculation that we have, into this calculator that we have, and see what the impact will be on your penalty. And so it's a good tool to use from a what-if standpoint. It's completely free. Again, you can download it at bessler.com/readmissions, and it makes the calculations a lot easier, and a lot of people have found it to be something very useful. And finally, I've got my contact information on the screen. If you have any questions about the presentation or about the readmissions program in general, feel free to shoot me an email or give me a call. I'd be happy to try to help. And with that, I think I'm done. I'm happy to answer any questions people have, but if not, thanks for your time.
Thanks very much, Jim. Does anybody have any questions? You can feel free to enter them in either the question section or the chat section, and we can get them to Jim. But if there are no questions, which as of right now I'm not seeing any, with that we will thank Jim, and thank you very much for your time. And again, if you have any questions, you can follow up with him directly, and the link to the slides to download is in the chat box section. Also on our website, on our webinars tab, you can go ahead and download that and follow up with him if you have any further questions. Thanks all very much.
Thank you. Bye-bye.